Okay, we're 2 minutes past the hour, and we have a good amount of participants that have joined us, and more will continue to come in. I wanted to thank you all for joining us today and dedicating time to learn more about caring for older adults with a history of trauma, findings and implications of our national survey on person-centered trauma-informed care. My name is Carmel Rabin, and I'm a project manager for research and evaluation at the Jewish Federations of North America. And more specifically, I work with my team at the Center on Holocaust Survivor Care and Institute on Aging and Trauma. I'm joined in this webinar by Shelley Reed-Wernick, who's the managing director of our center, and Barbara Bedney, who's the director for research and evaluation. Barbara is also my co-author on this study. Here at our center, our work really revolves around one central mission, and that is to expand the capacity of U.S. aging service providers to provide person-centered, trauma-informed care for Holocaust survivors, older adults with a history of trauma, and their family caregivers. In a moment, we're going to explain a little bit more about what we mean by person-centered trauma-informed care, or PCTI care. At the center, we have been working towards that goal, towards that mission since 2015 through federal grants from the U.S. Administration for Community Living. And as part of that grant funding, we were tasked with conducting a national survey on person-centered, or PCTI, care. And we're excited to share with you for the very first time today findings from our study and what they mean for your organization and those you serve. When I think about it, trauma is very much seldom talked about when it comes to aging and aging service provision, but trauma has a significant impact on our health and well-being throughout our life course. And that's why it's not only important to implement and provide services that focus on person-centered and trauma-informed care, but also to study and understand trends in that type of care. And when we studied this, we found out our main takeaway really was that there's so much progress being made in PCTI care, yet there's a lot of gaps in PCTI care to fill. Not every organization has the ability to provide PCTI care to clients, and not every client has access to the PCTI care they need and deserve. So we're seeing the growth of PCTI care, and that's really encouraging, and that's a point of pride, I think, for everyone on the call. But we also know that we have to continue this work as a community of aging service providers. So over the next hour, we're hoping to spend time with you in three main areas. First, giving you a background about our work and about the study, then giving you a little snippet of the highlights of the major findings of the report, and then review our recommendations for action. In addition to the information we're going to be sharing with you today, there's a wealth of information available on our report on the study. This report was released this morning and includes an infographic, an executive summary, and a full report with all of the data. For those who don't have the links to the report, we're going to be sharing them with you after the webinar. And we encourage you all to take a look, as this could be a really good resource for your organizations and for your work. A few housekeeping notes before we get started. This webinar is being recorded, and we're going to be posting the recording to our website in the coming week. And in the end of the webinar, we plan to have some time to go over questions and answers. So in the meantime, as we go through, feel free to put more questions into the Q&A function of the webinar. And before I hand it over to Shelley, I would just like to give a huge shout out and a huge thank you to the JFNA Board of Trustees and their chair, Mark Wolf, for their heartfelt support of this study and of the center's work. Also, we would like to thank the Center's Aging and Trauma Work Group, who really helped shape the study. And also, we would like to thank all of you on this call for dedicating the time today, but also for all of you who responded to the study and participated by submitting responses on behalf of your entire organization and advancing the study and the practice of person-centered trauma-informed care. Shelley?
Thank you very much, Carmel. As Carmel mentioned, I'm Shelley Reed-Wernick, the managing director of our center, and I've had the immeasurable joy of watching our impacts grow from infancy to today. Before we delve into the specifics of trauma and this research study, I wanted to offer a little bit of context. The Jewish community has been serving Holocaust survivors for decades, not just in the United States, but globally. And we've learned a lot. We know that Holocaust survivors carry a lot of pain and a lot of strength. And we know enough to use that strength to help them in their old age. The US government has recognized this expertise and has called on us to codify it as the person-centered trauma-informed approach. to write it down, foster it, grow it, develop it, and improve our knowledge based on the best research that's out there, and then employ the PCTI technique with Holocaust survivors and share what we've learned with all service providers to help all people as they age. My grandpa was a Holocaust survivor. My grandma is too. Holocaust survivors are our teachers and our heroes. And to this day, they're still teaching us, still helping us make this world a better place for all. And that's what brings us here. Can you turn it to the next slide, Carmel? Thank you. We're setting out to make the person-centered trauma-informed approach the universal strategy for serving all older adults and their family caregivers. Again, taking what we've learned from serving Holocaust survivors and employing it to be a universal strategy for all, so that everyone, everywhere, no matter their backgrounds or where they're getting services from, can get support to live their best lives. We do this in two ways. We fund subgrants to develop the person-centered trauma-informed programs, and we provide a mountain of education to build capacity to employ the PCTI approach. We're really proud of what we've been able to do as a system in the past 7 years. Our federal grant and associated matches has infused over $30 million into the system. That's $30 million that would not exist without the federal government's wonderful partnership. And look at what we've been able to do. Fund programs that have served more than 30,000 Holocaust survivors with some duplication for multiple grants. Train over 15,000 professionals on the PCTI approach. That's getting to that universal strategy that I mentioned. Support 5,000 family caregivers and 4,000 older adults who are not Holocaust survivors. And that's just the beginning. I'd like to now call on Dr. Barbara Bedney to speak more in depth about trauma and the PCTI approach. Thank you.
Thank you, Shelley. And I am here really just to give a quick background to get everybody on the same page about trauma, some of the impacts of trauma, and why we're here all talking about this. And there really is no one singular definition of trauma. Trauma is really in the mind of the beholder. What someone thinks is traumatic may not be what somebody else thinks is traumatic. It could be being a victim of domestic violence or of child abuse or a natural disaster, any or all of those things. But what tends to happen in a traumatic event is there's a loss of a sense of power and a loss of a sense of safety and a loss of a sense of control. And what tends to happen after that, there can be three primary results that can happen after a traumatic event. One is there can be increasing risks for declining health and well-being. That can be declining physical health, all sorts of effects, cancers, cardiovascular issues associated with trauma, mental health issues. So you have declining health that can happen as a result. You can have, as older adults age, they can be a resurfacing of traumatic behaviors and symptoms, even several decades after a traumatic event. And there's also an increased risk for re-traumatization. So somebody can experience a sight or a sound or a smell that can take them right back to that initial traumatic event and lead them to that anxiety and to the hypervigilance that can happen as a result of trauma and that can be felt during a traumatic event. And the reason that all of this is so important is because research tells us that as many as 90% of older adults have experienced a traumatic event, which means potentially that as many as 90% of the older adults that you all are seeing in your agencies are vulnerable to any or all of these risks. And that's why we're here really talking about person-centered trauma-informed care. So if we can go to the next slide. I think Shelley already talked about this a little bit, but the idea here is really to understand that many older adult clients and many older adults in general have had this experience of a traumatic event and incorporating that into service delivery. So really saying, okay, if many of my clients have a history of trauma, what does that mean? What can I do to promote their health and well-being based on that understanding that they may have a traumatic event? And essentially that means creating a safe environment and promoting their sense of safety and their sense of power and their sense of control to avoid any sort of re-traumatization issues during service delivery. Now, to be able to do that, that requires certain capacity, right? It requires an understanding and awareness of the likelihood that many of the older adults have experienced a traumatic event. It requires an understanding of what person-centered trauma-informed care is. It requires the capacity and resources to be able to implement person-centered trauma-informed care. And that goes to exactly what Shelley is saying, that that's a primary part of our role, is to increase the nation's capacity to provide person-centered trauma-informed care. Now, to be able to do that, we have to understand what the current state is in the aging network to be able to provide person-centered trauma-informed care. We have to understand what our impact is and what the current state of availability is to provide person-centered trauma-informed care. And that is really what our study is about, to really understand the current state of awareness and capacity to provide person-centered trauma-informed care and the impact of the center and where we go from here. So I just want to echo Shelley and Carmel and say thank you very much for joining us. Thank you very much to everybody who participated. And with that, I'm really excited to turn it over to Carmel and have her take you through the study.
Thank you, Shelley and Barbara. Like any good research project, we started off with our research questions for this study. And the research questions, going back to what Barbara and Shelley have mentioned, were really guided by our grant and our field of study. So in terms of our grant, our research questions needed to review the state of PCTI care in the US and also needed to assess the Jewish Federation's impact on that PCTI care awareness and capacity. But our research was also grounded in our field of study. So prior to this study, there was no existing data set or study on the topic of national trends in PCTI care. Of course, there was some data on person-centered care, some data on trauma-informed care, but none about this new and innovative model of PCTI care. And that's why we set out with our research questions to have an exploratory study. This study, the purpose of it was really to produce a baseline on what the national trends are in PCTI care and give us a good starting point. A starting point to have a shared understanding of national trends, to conduct future research, and to benchmark progress and change. And so with that said, our questions were fourfold. First, we were curious about awareness. We wanted to understand what the level of awareness is among aging service organizations about the role of trauma in the lives of older adults, and also the level of awareness among aging service organizations about the PCTI care approach. Our second question was then focused on capacity, and we wanted to understand what the capacity of these aging service organizations was to provide PCTI care to Holocaust survivors, older adults with a history of trauma, and family caregivers. So not only understanding awareness of the PCTI model, but how organizations are turning that awareness into practice through active capacity, PCTI care capacity. Our third question was then surrounding the topic of benefit. We were hoping to explore what aging service organizations see as the benefit of providing this type of care, PCTI care, through their organizations and to their clients. And finally, we were curious about the center's impact. We wanted to know the impact of the center's work on the ability of aging service providers to provide PCTI care to their clients. And in order to answer each of our research questions, we conducted a short online survey. The survey was reviewed by our Aging and Trauma Work Group, which is composed of about 15 members representing diverse aging organizations and communities. They provided us with really invaluable feedback on our survey, helping ensure that it would be inclusive and welcoming to diverse communities to participate, and also ensuring that we were asking the right questions. The survey itself included subjective and objective metrics. When I say subjective, I mean perceived self-reflection of organizations. When we talk about objective, we mean demonstrated, actual, unbiased reviews. And the survey also included a mix of qualitative and quantitative questions. Qualitative questions were open-ended text-based responses, and quantitative were multiple choice or ranked questions. As a result of having that 15-minute online survey out for about 2-3 months, we got a sample of 195 organizations that participated. Our sample was composed of US-based aging service organizations, so every one of the 195 survey responses were completed by one staff member who completed the survey in representation of their entire organization. The survey itself was completed mainly by executive and senior management of organizations. You may be curious about what we mean by aging service organizations who could qualify for this study. And for us, any US-based organization that serves older adults in any capacity was eligible to participate. So our sample included over 20 different types of organizations, such as hospitals, legal service organizations, social service agencies, organizations working on issues of elder abuse, nursing homes, foundations, and a lot more. We also had organizations representing a wide range of service populations, including Holocaust survivors, veterans, immigrants, Asian Americans, African Americans, and the list goes on. And our sample was quite diverse in terms of organization size, sector, religious affiliation, and geographic location. Once we collected all of the data, we analyzed it through a Power BI data model, and Power BI is a business analytics software. Through that program, we were able to conduct our qualitative and quantitative analysis. We coded open-ended qualitative responses for themes to draw out what participants were saying generally across the survey, and we used descriptive and inferential statistics on the quantitative data. In addition to these standard methods, we then developed an organizational PCTI care capacity index. We developed it specifically for this research, for this study. This index was based in literature on organizational capacity and enabled us to objectively assess an organization's level of current PCTI care capacity. This index does not rely at all on an organization's self-reflections or perceived views of their capacity, but rather it uses 15 standard indicators of their performance. The indicators spanned 5 standard areas of organizational capacity, including resource, infrastructure, partnership, knowledge and skill, and organizational climate. For example, we had an indicator that asked the question, does an organization have written goals establishing PCTI care as part of their organizational mission? Or does an organization train staff on PCTI care? And like any good research project, our data has limits, our findings have limits. Our study was conducted during the COVID-19 pandemic. And so with that in mind, we have to take our results with a grain of salt. Maybe more organizations knew about trauma during the COVID-19 pandemic, but maybe less could participate in this study. Even though we have to take our findings and limitations kind of with a grain of salt, nonetheless, this study really provides us with a great starting point to have a conversation about PCTI care capacity and awareness and to collaborate on future evaluations in the future. Yep. Okay, awareness and understanding. So what did we find? We found out that 72% of our organizations that participated in a survey were aware of PCTI care prior to receiving the study. We also learned from our sample that 58% of the organizations reported having a deep understanding of what it means to age with a history of trauma. So what does this mean for us? First, I find it really encouraging. So many organizations, 72%, so many organizations recognize PCTI care as a model to serve their clients. And 58%, that's a large percentage there, understand what it means for their clients to age with a history of trauma. But these percentages also represent all the work that we have to continue to do. There's a significant amount of organizations, 28% to be exact, that don't know of the PCTI care model and therefore can't provide PCTI care to clients. And over 40%, 42% felt that they had moderate, low, or no understanding of what it means to age with a history of trauma. And if we go back to the statistic that Barbara mentioned a little bit ago, we know that 90% of American older adults may have experienced a traumatic event in their lifetime. So we need to see both the 72% and the 58% go a lot higher. So these stats really serve as a baseline, remember, because we don't have what this used to be a year ago, 2 years ago, 5 years ago. And so they help contextualize each one of our organization's work and moving the needle on awareness and understanding. Barbara?
I think the idea of moving the needle is really key here, and I find these results very fascinating as well. And I think what you're starting to see is this continuum of what it takes to have the capacity to do this. And the first thing is that awareness. And awareness is a bit easier. You can be aware of something and yet not understand it. And the more we get closer to actually being able to implement something, the harder it gets. So exactly, I agree with Carmel said, these numbers are very exciting, but there's a lot of work we need to do, again, to increase awareness. And then once you're aware of something and you're aware of person-centered trauma-informed care and you're aware of the impact of trauma, then you have to understand it, and then you have to go forward again and do something about it. I think we're going to see these trends going further.
And that brings us perfectly to the next slide to talk about PCTI care capacity. So beyond awareness, we really wanted to understand how capable organizations were of turning that knowledge into action. And for that, we explored capacity in two main ways. First, subjectively as a self-reflection of an organization, and then objectively through the organizational PCTI care capacity index. We wanted to see how organizations felt about their capacity and also how they objectively demonstrated that. And we found out that 55% of the organizations in the sample self-reflected, perceived that they had high or very high capacity to provide PCTI care to older adults. Comparatively, only 30% of the organizations in our sample actually objectively demonstrated having that high or very high capacity to provide PCTI care. And I think these statistics have implications for our work, regardless of whether you're looking at the 55% or the 30%, there's a wide gap to fill. Many organizations simply do not have the capacity to provide PCTI care to their clients, and we all have work to do to move the needle on these numbers. Also, you can see 55 and 30% are not the same number. Organizations we found tend to overestimate their PCTI care capacity. This represents a really massive opportunity for all of us to educate and build capacity. Once we have a bit more of a realistic view about what it means to have PCTI care capacity, we can work to achieve it. And for this purpose, we encourage you all to open up the report and look at the Organizational PCTI Care Capacity Index and find the specific areas where your organization can work to improve PCTI care capacity. Barbara?
And I would agree again, and you can again start to see that continuum from being aware of something to have an understanding of something to having the capacity to do something about it, let's say to provide person-centered trauma-informed care. Carmel used the phrase, there's a wide gap, and there is certainly a gap between awareness and understanding, and then the gap grows a little bigger between having that understanding and having the capacity to do it. But it also tells us what we can do going forward and how we can fill that gap through knowledge, through education, through resources, and all of those things. And I think, again, we're going to see that going forward. I think what's also interesting here, again, is that difference between the subjective and the objective capacity. I think there's a lot there in terms of what that tells us, in terms of what agencies think they're able to do, what they objectively have the capacity to do, and again, how we can have an impact going forward on those numbers. So looking forward to a discussion about those numbers as well.
And that gap doesn't only exist between awareness and capacity, but it also exists within the topic of capacity. So next, we wanted to see how organizations' PCTI care capacity was spread across diverse client demographics. And as you can see on this slide, without much surprise, we found that there are disparities in care. In order to study this, we asked organizations to rate their capacity to provide PCTI care for each of the older adult demographic groups shown on the screen. And you can see we asked organizations to rate their capacity with regard to Holocaust survivors, family caregivers, disaster survivors, Asian Americans, and so on. We then compared this rating against those demographics the organization already said that they currently serve. And when having this comparison, we got some really compelling data. So I'm going to go to the very top line of this chart. We found that 54% of organizations actively serving Holocaust survivors noted that their organization has high or very high capacity to provide those Holocaust survivors with PCTI care. And then I'm going to jump all the way down to the bottom line of the chart. 18% of organizations serving American Indian, Native Alaskan, and Hawaiian Native older adults reported the same type of capacity to serve people from this demographic with PCTI care. So as you can see, this really shows the wide disparity in PCTI care for diverse demographic groups. When we look at these stats, they're not a huge surprise. Disparities in care for diverse populations exist in many health and social service settings, and this is quite quite well documented, but this does show that PCTI care is no different. And then we need to integrate an equity lens into our work in PCTI care as well. Barbara?
It's hard for me to add much to that because I think you're exactly right about the equity lens. And that's important here. It's important to look at what this data means in terms of those disparities. Again, I guess none of this is a surprise, but it does tell us where to go next and what we need to do and what areas and populations we need to really work on going forward to make sure that they can access and benefit from person-centered trauma-informed care. So this slide, again, looking forward to some discussion about it, but it really does provide a roadmap for us about where we can go next and to take person-centered trauma on the person-centered trauma-informed care on the road to newer populations who can benefit from it.
Absolutely. So beyond awareness and capacity, we also wanted to explore how organizations perceive the benefit of PCTI care. For professionals and organizations to take on PCTI care, to implement it through their agencies, it really requires seeing the value in this type of model. And with that in mind, we asked survey respondents what they saw as the benefit of providing PCTI care through their organization and to their clients. And just as a caveat, before I reveal some of the data on the topic, in the survey, this was asked as an open-ended question. And that means the data I'm about to show really represents the top of mind responses of survey takers. This data should very much not be seen as an exhaustive or ranked list of benefits. There are probably more benefits out there. It's simply an initial take on some of the benefits that people see from PCTI care. And the responses we got can be bucketed into three main areas. First, respondents touch on that PCTI care can make improvements to the client experience. Respondents noted that PCTI care could, for example, improve decision-making of clients, staff, and family caregivers. That providing services through a PCTI perspective or approach brought in family caregivers into the decision-making process, and it allowed staff and clients to have more information and better information to make decisions. Another example is that PCTI care could also improve client empowerment, which should be no surprise as it's part of the model, to allow services to be centered around what the client wants and what the client needs, and also respect their voice and choice in all of the decision-making going around service delivery. Additionally, respondents noted that PCTI care improved safety, not only safety for clients, but also safety for staff. A few respondents noted that staff gained physical and psychological safety by, for example, understanding client behaviors, knowing how to avoid challenging situations as well. Respondents also touched on another area, which is that PCTI care made improvements to the client outcomes. So PCTI care not only helped improve the client experience, but also the outcomes of those experiences. Respondents noted that PCTI care improved physical health, well-being, socialization outcomes, and also improved service access of clients. So with a greater understanding of the client and a better relationship built, staff can refer clients to more or more fine-tuned services, and clients might be more likely to take advantage of those services. A few respondents also noted and touched on the aspect that PCTI care can really make improvements in client mental health outcomes. And with that, PCTI care helped destigmatize mental health service and increase the likelihood that older adults would take advantage of mental health programming. And then the third bucket that respondents touched on was that PCTI care could benefit by making improvements to the organization itself. Not only did respondents note that PCTI care would be beneficial to their clients, but also to the organization through having a structured work approach for staff, through improving staff knowledge, improving quality and quantity of services delivered, and also improving organizational sustainability. A few respondents noted that incorporating the PCTI care approach made their organization and programming more attractive to outside funders. So this means for us, first, that there's a diversity of benefits of PCTI care approach, and these are most likely not the only ones. So we're excited to explore even more benefits of PCTI care. And second, that this limited list still might be a really good motivator for professionals working on PCTI care. Implementing PCTI Care requires dedication and effort on the part of every staff member. And being able to forecast some of these benefits could help, could be encouraging, could build momentum, can be used in trainings, capacity building initiatives, informational resources on PCTI Care. And something that I'm really excited to see, and I think is very important, is that respondents noted that PCTI Care is not only beneficial to clients, but the organization. PCTI Care often requires organizational buy-in of executive and boards, active commitment of leadership, and the organization itself to dedicate resources. The more organizations that can see the benefit of PCTI Care, not only for client, but for self, the easier it is going to be to get more organizations across the United States on board with PCTI Care. Barbara, did you want to add anything here?
The only thing I would add here is as an evaluator, you'll always want to see that benefit question, and you always want to see the data that comes up of the benefit of what you're doing. And it really comes across very nicely here. And what comes across here is that there are in fact multiple benefits in multiple different categories as a result of providing PCTI Care. And that's in terms of the actual experience of providing services. It gets to, again, client outcomes and improvements to organizations as well. So again, from this slide, you really start to see that the multiple benefits across the board in all these different categories and in all these different ways. And that's one of the benefits of asking that kind of more open-ended question, is you can sort of see all these different impacts across these different categories. So we are very, very excited about this slide, again, to see the multiple impacts and multiple different ways that PCTI Care is having on clients and on organizations.
And all of that brings us to the last data point that I want to share with you today, and that's the impact of PCTI Care funding. As I mentioned at the beginning of this webinar, through the study, we wanted to understand the impact of the center on PCTI Care capacity. So in the survey, we actually asked respondents whether their organization was ever funded by the center in any capacity. And this means that we were able to compare those organizations that had received center funding from those organizations who had never received center funding. And in the end, about 30% of our sample received center funding or was a center subgrantee at one point. When we looked at these two different pools of organizations, we saw that center subgrantees tended to do better across all measures of PCTI Care awareness and capacity. In particular, center subgrantees fare better on measures of objective and demonstrated PCTI Care capacity. As you can see on the screen, 70% of organizations funded by the center demonstrated high or very high capacity to provide PCTI Care to older adults. Comparatively, only 9% of organizations which never received center funding demonstrated that same high or very high capacity to provide PCTI Care. This is something we're, of course, very proud to see, but this is not all that surprising because center subgrantees, as part of their subgrantee status, as part of receiving funding, they get a lot of capacity building support from our staff. They get funding dedicated to learn about PCTI Care and topics of aging and trauma. They receive funding to implement PCTI Care programming, and they get funding to improve their organization's PCTI Care capacity. And so the point I'm trying to make with the 70% and the 9% is that I hope to showcase here that funding can make a really big difference. It doesn't necessarily need to be center funding, but funding dedicated to PCTI Care can really make a difference in the ability of an organization to provide that care to their clients. So if you are on the call here today and you typically receive funding, know that seeking funding on the topic of PCTI Care and implementing that funding can really have a great impact on your organization. And if you are a funder, know that providing funding focused on PCTI Care can really lead to measurable results. Barbara?
And again, this goes back to filling that gap that we were talking about, that those gaps between an awareness and understanding, and then that gap between understanding and capacity. And obviously from this slide, we can get that funding is a real good way to start to fill that gap to funding to provide those kind of the technical assistance and support and those programs that we're talking about here. So again, this slide really gets to the importance of funding. It gets to the importance of what we're doing and what we can do going forward. So really important slide here as well.
And in terms of what we can do going forward, I wanted to highlight the 5 recommendations that are in the report based on the findings of the study. And no matter your position or experience, you and your organization can make a difference and move the needle on PCTI care. So in terms of our first 2 recommendations, we wanted to encourage you all to raise awareness on the topics of aging and trauma and about the PCTI care approach. And that could mean, firstly, by educating ourselves a bit further, complete trainings, listen to clients, talk to other people that work in the space, other organizations that are doing this work about what it means to age with a history of trauma and what the PCTI care approach is and how it can be implemented. And if you have this knowledge, going out and sharing it with your colleagues, sharing it with your team, with your entire organization, with your professional networks at conferences, at other professional events. In addition, our third recommendation is that we deepen organizational capacity to provide PCTI care. Simply knowing about the impact of trauma on aging or that the PCTI care approach exists doesn't necessarily give us the ability to act on it. So learning about PCTI care, that's the easier part of the journey. Having capacity to provide that PCTI care, that's much harder. And that requires organizations to make investments in their staff, their culture, their procedures, their priorities. And we really all have a responsibility to deepen our individual and organizational capacity to provide PCTI care to clients. I, again, would recommend taking a deeper look into the report to look at the organizational PCTI care capacity index. And from that, figuring out the specific areas that make sense for your organization to deepen its PCTI care capacity. Now, imperative to providing PCTI care capacity to clients is to acknowledge and overcome disparities in PCTI care. So in order to make PCTI care available to all, we have to recognize that not all clients have equal or equitable access to PCTI care. And not all organizations have capacity to provide PCTI care among all the service populations. So we need to individually and as organizations uncover what this means in your specific context and find solutions that fit your organization and your community to move the needle. And finally, we need to provide more dedicated resources for PCTI care. Providing resources can really make a significant difference for organizations and the clients they serve. And so while there is a lot of work left ahead of us, we can feel really proud as a community of aging service providers that we've made so much progress over the last few years, and that collectively we're able to continue growing and improving client care. Before I go into the Q&A session, that will be the next section, Shelley, Barbara, did you want to add any final thoughts?
I do. Thank you so much for asking, and thanks for walking us through the report. I have a question on a distinction in funding. Is there a distinction between funding of a PCTI technique or program or innovation and funding for the capacity building? For example, we often talk about how it sometimes is very cheap, inexpensive to make something more person-centered and trauma-informed, like such as an intake form. You can revise the questions and that doesn't cost a lot of money. Or, having plated meals with plastic Ziploc bags so that people understand that there's plenty of food to go around and they're welcome to take food home. Those plastic bags don't cost a lot of money. So that's not really a funding thing. But the training and the education to know what would make a program more person-centered, trauma-informed does take some money and training. So can you talk a little bit about that distinction? In other words, I want to be encouraging in that the capacity does take dedicated resources, but implementing the programs, once that capacity is there, doesn't necessarily take a whole lot of resources.
Absolutely. And I think I'm just going to go back to the last slide for an example. There's a reason that 9% isn't 0%. Without dedicated funding, you can still improve your capacity, your organization's capacity to provide person-centered trauma-informed care. It's leveraging what already exists, putting more funding towards it that can really yield great impact for an organization because it can provide more dedicated time, more dedicated staff to develop this. But yeah, if it all took money to do, that 9% wouldn't exist there, because we are the only funder right now in the space providing funding specifically for sub-grantees to do PCTI care work. Barbara, I don't know if you have any additional thoughts on that.
I think it's a really good question and a really good point. I think capacity could be any number of things. Again, it's training staff, and which can require resources at times. It can be, you know, creating a physical space. It can be, you know, making art that's, you know, culturally appropriate and making people feel safe. It could be lighting. It could be changing intake forms. It could be the way services are provided in general. It could be, you know, being aware of specific trauma triggers for different populations and understanding that and minimizing those. So there could be a whole lot of things that go into creating that sort of person-centered trauma-informed environment and culture of care, some of which may in fact be more costly than others and take more time and more resources than others. I think the important part here, or one of the important parts here is starting that journey, right? And figuring out what agencies can do to get started where they are now in terms of their capacity to provide person-centered trauma-informed care in general and to diverse populations, and seeing where they can go next, and then figuring out how those resources can play into that dynamic. But I think part of that is just taking a look now and saying, okay, where are we now in terms of this, and where do we want to be, and how do we get there? And let's start that journey now.
And to clarify, our funding and our work centers around person-centered trauma-informed care for older adults. There's been a lot of work by a lot of different organizations that focus on trauma-informed care work and capacity building for that, for children and for families, and rightly so. But this study and the focus of our work and the focus of our center is really on the older population.
I see a question in the Q&A box about clarifying how we measured objective PCTI care capacity. We have several pages included in the report with a detail of the 5 different capacity areas with the 15 different indicators and how we arrived at selecting those areas and those indicators. I very much encourage you to look at that, because that might also be helpful for understanding what PCTI care capacity can mean for your organization as well. And I think with that, we will jump into Q&A. Abby, are there any questions that have come in?
Hey everyone, I am the project assistant. I work with Carmel, Barbara, and Shelly, and yes, we have a few questions we have received. The first question is, did the study ask the percentages of client groups served by each organization? For example, 75% of X organization's clients are served are Holocaust survivors, 10% are African American, etc.
In the study, we didn't ask the percentage of an organization's demographics in different categories, but we did ask for organizations to just check off a list of which client groups they did serve. So we have that information, and we have the percentage of our total sample of how many organizations serve African Americans or Asian Americans and so forth.
And then can you talk about the general populations of the organizations that responded? Were there types of organizations that were not represented?
We got so many different types of organizations. Most were social service agencies. We were encouraged to see that there were a few legal service providers, healthcare systems, and hospitals. I think I would have liked to see more of that. Everyone in the work that they do serves older adults in some capacity. So I would have liked to see more healthcare settings join in, more legal services join in, and maybe they will in future iterations of this study. I don't know if, Barbara, you were looking for a certain type of organization as well.
It's a great question. I know we have probably numbers that say what type of organizations participated. I think the question is getting to, you can do this approach anywhere when it comes to older adults. And that's why we were looking at different populations. So how you can provide person-centered trauma-informed care in a nursing home may be different than how you do it when you're providing legal services, may be different when you're providing technical support, whatever else it is. Again, the idea is to be able to take that approach and an idea of promoting safety and trust and empowerment across the board in whatever it is that you're doing, which is why we tried to get as broad a population to participate as possible. And I believe we do have some numbers in the report about different types of agencies that participated.
Yeah. And one thing that just came to mind is that The sample was really diverse in the type of organization. For example, there were organizations serving less than 100 staff. There were organizations that had less than 100 staff. There were organizations over 1,000 staff. There were organizations, private sector, public sector, social sector. There were organizations that were religiously affiliated and not religiously affiliated. And we also have a breakdown in the report of what religious affiliation is there too. Do we have another question, Abby?
Yes, one thing I have is, can you clarify what you mean by PCTI care capacity? Does the full report have the questions included in the index?
Yes, I think we covered that a little bit. I would very much encourage you to take a look at the report. We have, I don't have enough time on this call to go over the pages that we have about how we defined it, but it's very much written all there.
And can you remind everyone how they can access those reports?
Yes, absolutely. So you should have received an email this morning, hopefully, if it didn't go to your spam box, with the report links. You can also visit our website, agingandtrauma.org, to take a look at our publications. Also, at the end of this presentation, we're going to be sharing with you a recording of the webinar and links to all of the reports again.
Great. And then one more question I have is, you mentioned that you objectively evaluated the organizations. How did you do that? Was that just rating questions, or did you visit each site and evaluate how they provided care?
I would love to visit each site and learn so much more about how each organization provides care, the nuances, the details there. We were limited to a 15-minute online survey. So we created an index of 15 indicators, and what organizations saw when they completed the survey was one question with a list of sentences that they can check whether that's true or false for their organization. So that's primarily what the objective PCTI care metric was based off of. But again, would love to take a US tour to learn more from organizations.
Great. Okay. And then I have, can you expand on measuring the demonstration piece? As in, what is in the criteria met for demonstrating PCTI care?
So I can give you an example. Objectively demonstrating PCTI care, we measured, for example, if you have staff capacity or if you actively train. So we asked organizations, do you train staff in PCTI care? So we didn't necessarily measure a spectrum of how knowledgeable are you on PCTI care, but is that something that you provide your staff with? So do you have capacity in terms of PCTI training for your staff? We set up all of the 15 indicators like that to be measured in the survey. So they're similarly actually asking for actively demonstrated capacity. And that's also the 15 indicators that we have. They're more than likely not a exhaustive list of areas of PCTI care capacity, and we're very much interested in having conversations with all of you about how that can be further refined.
And Carmel, I think some of those were based on a literature review talking about what organizational capacity is and the different components of organizational capacity. So we sort of used that and combined that into the tool that Carmel developed.
Very much true. We based it on the literature review, and then we made modifications to apply it to the practice of PCTI care. So very much grounded in research, but always could use further refining.
And knowing that the study shows less PCTI care for Native Americans and other minority populations, how does the center plan to use this data to further work with these populations?
I think the first part of action is knowledge about where those gaps are and critically assessing which members of our community have access and which ones don't. I know that Shelley can probably talk in a lot more detail about the expanded mission of the center. I know that in 2015, we received a grant exclusively for Holocaust survivors and their family caregivers. And in 2020, we received another grant to expand these services to additional populations. And it's important to note that because the study mainly focused at the first 5 years of the grant. Shelley, would you like to add more details there?
Sure. And I will add that we are just one part of this picture. We want this report to be used by many different organizations to be a roadmap for how to develop tools to build capacity in person-centered trauma-informed care for all the populations that they serve. We want to offer webinars. We want to present at conferences. We want to talk to as many different audiences, different types of service providers, different demographics as we can, but we are only, a handful of people to do that work with. And so all of you on this call, we want you to also, kind of take up that charge and help present the benefits of PCTI care and the ways to build capacity viewed through the recommendations in this report to, all of the organizations that you work with. And we're available to help you do that. But our influence is limited, and we really want to get this information out there so that others can use it.
Can I just add to that real quick? I just agree with that. I agree with that. Amazing. And I think part of it is partnerships, and part of it is thinking about, we're really creating a field here, right? And creating a field of person-centered trauma-informed care. And it could be, what does it mean to create safe and trusting and empowering environments across the board? What does it mean for different populations, for different older populations? How do we do this for every population that's out there when an older adult comes to seek services? So I think it's understanding and working together to really look at maybe different trauma triggers and what is a safe environment and all of those things across the board. So I just agree with what Shelley said amazingly. I think this is about partnerships and working together to create this field and move it forward. So thank you. That was a great question.
Another question we have is, did you ask questions about the types of staff, such as social workers or nurses, involved in the PCTI care of each organization?
Saw that question. I think it's excellent. We did not ask it in this round of the survey, but it's definitely an area that we could examine further in future iterations of the survey. The majority of respondents that spoke on behalf of the organization, again, were executive and senior management. There were also direct service providers that responded to the survey as well.
I see we're running short on time. Do we have only 5 minutes left? Is that the case?
Yes.
Okay, so in the interest of time, Abby, if it's okay with you, I'm going to scroll through these questions and just shout out quick answers so that we can get through as many as we can as possible, if that's all right. So one question I see is, do we provide PCTI care training for organizations that have not received our funding? And the answer is yes. Our webinars are open to all. We put publications on our website. We're always adding new publications. We put our webinars up there. We're writing articles that we put up there. And so we want to direct you to that website again, agingandtrauma.org, and you can view all of our resources. We're actually in the process of launching a new website, so it'll be even easier for you to find all of that, but we can provide that level of training. And then when it comes to more, customized webinars, please reach out and ask. And, if we can, we want to do that for you. And if we can't, we want to get you the resources that you can use to get that type of support. A couple other comments I'm just going to read out. The importance of spiritual care and pastoral care in person-centered trauma-informed care. I agree, very, very important. And a lot of the organizations that we fund are able to offer person-centered trauma-informed spiritual care. Some comments about nursing homes and long-term care settings and challenges with staffing shortages, which we are hearing across the board in direct care. Service providers may have made it difficult to complete this survey, as Carmel said, when we issued it at the very beginning of the COVID-19 pandemic. So, if we could, I'd want to do it all over again now, but we're not going to do it now. We will do another kind of survey in about another 4 years. Let's see. Okay, that question was answered.
Are
there certain
about how person-centered care and trauma-informed care are different from person-centered trauma-informed care? Am I getting that right?
how the distinction between the trauma-informed part and the person-centered part.
Yeah,
I
and
think that-
how it's new as a PCTI term.
Barbara, do you want to take that one?
I think person-centered care has been around for a while in terms of social work, at least as far as I can remember. The idea of adding trauma-informed to it is again accentuating the point that many clients have that history of trauma and really being able to focus on it while you're providing person-centered trauma in person-centered care, and just incorporating that awareness and that knowledge that somebody you're working with might have that history of trauma. It might have impacted their health and well-being. It might be impacting them as they age. It might, impacting their risk factors going forward. So I would say it incorporates that and just accentuates that trauma piece a little bit more as you're doing person-centered care.
And I think I can speak to the one other question that remains in there. We did receive, I believe, a few survey responses from organizations working on elder abuse issues. So that was included in there. In terms of organization groups that were not, or groups of organizations that were not necessarily part of our study, I think we opened it up to all, and we would encourage you next time we do the study to send this out to as many organizations that you know to make it more inclusive next time, even more inclusive.
And Marion, your question about areas for PCTI training, different types of professions such as doctors, social workers, home health care aides. Yes, dentists. I will throw out there for you in particular as well, as I know you care about that a lot. All of the different service areas where older adults interact with, and I would say not only in the provision of direct services, right? So we're talking about doctors and medical professionals, but also librarians. Also people who drive the vans that older adults use to get from place to place. So really anyone who interacts with older adults, those types of organizations could really benefit from this type of capacity building initiative.
I think we have 2 more minutes. I think I'm gonna wrap it up, and we'll see what other questions we can get to maybe in an email response afterwards. Thank you so much for joining us today. Thank you for dedicating the time to learn about national trends in PCTI care. If you're interested to learn more, read the report. We have so much data in there. I'm sure you can find a piece that's relevant for your work, and it would be a good resource for your organization. In the next few days, we're going to send an email out to all those who attended and registered for the webinar. That's going to include the webinar recording, links to the report, and a brief questionnaire. The questionnaire will take about 3 to 5 minutes to complete, and we'd be really grateful for your feedback. Your answers will help us find topics for future research that are important to you that we can integrate into our evaluation next time. It will help us improve future webinars. And kind of in closing, we want to keep the conversation going. Please don't hesitate to reach out and contact us and find ways to collaborate on PCTI care. Shelley, Barbara, any closing words?
Thank you all. It's really a pleasure working with all of you, and we look forward to moving this forward. Thank you.
Thank you.
Absolutely right. Take care, everybody.